Hi everybody, I'm Dr. Stoner. So our topic for tonight is to increase productivity in the hygiene department. We're hoping to learn that three primary objectives: to diagnose more perio in your practice, to choose the most effective local anesthetic to assist the hygiene team, and to learn a new technique, which is a needleless system to encourage the hygienist for increased participation in her department. So let's get started. Let me tell you a little bit about myself. I'm Dr. Stonish, and I'm a 1987 graduate of the University of Detroit Mercy School of Dentistry. I'm an AACD accredited member and a COIS mentor. I also have a diplomat status with the ICOI, International Congress of Oral Implantology. I've been practicing general dentistry since 1987. And I opened a CT scan center and an implant center in 2016. I really do enjoy the practice of general dentistry, and I'm hoping to share a little bit tonight with you about how the periodontal component to my practice has really blossomed. And you know, they say you can be sick and have a healthy mouth. No, let's start that again. You can be sick you can, let's see, you can be sick and have a healthy mouth, but you can't be healthy with a sick mouth. So periodontal disease is really prevalent, important, and it needs to be really addressed with all of our patients. And we also know today that these periodontal pathogens really can lead to stroke and heart attack. It isn't that it's just some mysterious questionable possible link. There is absolutely a link between perio and heart disease. So it is our obligation as healthcare providers and dentists to educate our patients, and I'm looking forward to helping you a little bit today with some of the knowledge I've learned through John Coyce and some of the other courses I've taken. So to give you an overall kind of outline of where we're headed tonight, first and foremost we need to talk a little bit about pain and what it is. We're going to talk a little bit about anesthetics and the history of anesthetic and anesthesia, and then move on to specifics on what I believe to be the best anesthetic that has helped me in my practice specifically for the last 10 years or so. And I'm hoping that after this presentation you'll agree, and if you're not currently using it, you might begin, as well as incorporate it into your hygiene team. And finally, the last two categories, a little bit more about periodontal disease and how I choose to tackle it in my practice. We practice a medical model for every facet of dentistry in my practice. And what does that mean? That means that we are constantly looking and recommending treatment options to decrease your problem to an emergency or decrease the probability of you having a problem in the future. So that being said, as well as in periodontal disease, we are really trying to be proactive about perio, and I'll take you through my perio assessment model as we move forward. And finally, the last part of our lecture, we are going to talk about a needleless system for administering anesthesia, local anesthetic. It's been kind of just a fun little gimmicky tool that's great on little kids, and it's great when you just need a little anesthetic at a crown seat to get some cord in there to really get a perfect seal around the crown margin. And now I've added it to our hygiene department, and the team has really embraced it, and it's been fun to see them increase case acceptance because the patients aren't as fearful of a needle because there isn't one that they see. And it's just been really kind of exciting to incorporate this new needleless anesthetic system. So let's get started. And first of all, no pain, no gain. Do we really believe that? Not in dentistry. Certainly we are trying to limit the pain that our patients experience. And what is pain? Why are we here today? Pain is what patients fear the most, isn't it? I know for myself, I don't like being on the receiving end of dentistry myself. And pain is what I fear the most too. not only in dentistry but in general. And pain is not well understood. For most patients, the one thing they remember the most about their dental visit is whether they had pain or not, correct? So I'm more inclined to give an injection to be able to block that pain transmission and keep the patient comfortable. And as Dr. John Coy says, the needle's not the hitman. The needle's the hitman, not me. So we need to understand pain and help all of us in this understanding of pain. We can help all of us treat our patients a little bit better. So what is the definition of pain? Pain is an unpleasant sensory and emotional experience associated with actual tissue damage or sensory feeling, potential tissue damage, or just as it can be described as such. So pain really is whatever the patient says it is. You know, what do you want to do? Say just tough it up? No. You know, it is truly, if a patient says they're in pain, that's what pain is. And oftentimes we rate pain on a scale of 1 to 10. How much pain are you in? So that can give us a little barometer as to, you know, what the patient is really feeling. So as we move forward, how does nociception work? First, there's a contact. You know, we feel something. There's a stimulus, and it can be mechanical or it can be chemical. And there's a receptor that receives this stimulus, typically that nerve ending that receives this stimulus. And then there is transmission along the nerve to the central nervous system where the brain processes the information that it receives. So let's go through and talk about these points in a little more detail. First of all, there is a contact. And that initial contact can be either mechanical with pressure, puncture, or a cut, or it can be chemical, as in a burn. And next, the receptors. There are primarily 3 different types of receptors: alpha mechanosensitive receptors, alpha mechanothermal receptors, and C fiber receptors. The alpha receptors are typically lightly myelinated and fast-conducting neurons, both the alpha mechanosensitive and thermal sensitive receptors. The mechanosensitive are responsible for mechanical stimulus, of course, of pressure and touch, whereas the mechanothermal receptors are responsible for mechanical stimulus, pressure stimulus, touch, as well as heat. And the C fibers are unmyelinated and slower conducting neurons. They're responsible for a variety of stimulus. And how about the transmission of this stimulus? The nerve ending senses the stimulus, and it sends the stimulus to the central nervous system. At the central nervous system level, once it gets to the brain, further processing occurs. So this is what the pain pathway looks like. First of all, there's a stimulus, which is received by the nerve ending through the spinal cord to the brain synapse, in which the spinal thalamic tract processes the stimulus through the thalamus, and finally it gets to the somatosensory cortex, in which the brain processes, and we can receive it and acknowledge pain. So how do we handle pain? We can either reduce the stimulus, block its transmission, or alter the experience. Reducing the stimulus would mean using sharp instruments. Certainly we don't want to use dull instruments in treating patients. Reducing the pressure applied, controlling the temperature, and reducing the vibration. In my practice, we do use electric handpieces and often lasers, and I found both of those seem to be obviously much more pleasing to the patient. We can block the transmission through local anesthetic, which we're talking about today, or the gateway theory, the gate control theory. And when we're talking about anesthetics, an ideal agent, just when we're generally thinking about what we're looking for would be one that we want to take effect immediately and be quick. We want it to be profound. And we want it to have little toxicity to our system and little allergenicity. So let's talk about a little bit about the history of the first anesthetic on the scene, which was Novocaine, and it came on the scene in about 1904. This early anesthetic agent belonged to the ester group, and while it was acceptable, it wasn't really ideal for the reasons that we previously mentioned. It wasn't necessarily that immediate. Profound anesthesia wasn't, and it did offer some allergenicity and some toxicity. So although it did work, it was still falling short. And in 1948, amide agents were invented. The benefits of an amide is they are quick. They follow these 4 principles that we are looking for. They're quicker onset, longer duration. However, in general, the amides were a little more allergenic. They were less, I'm sorry, the allergenicity was the factor that gave amides an advantage over the esters. And the amide agents were far less allergenic than the ester agents. So as we move forward, we were able to control this allergenicity a little bit better. The first amide was lidocaine, and it was the first amide to be marketed. It was quickly replaced with Procaine as the dental local anesthetic agent of choice in the 50s. And as we progressed another 50 years, as of 1996, the last remaining ester local anesthetic was produced in a dental cartridge. It was a combination of Procaine and Propoxycaine, and it was removed from the U.S. market at this time. Available today, there are 5 injectable amides, and since we're talking about hygiene today, all these amides can be used by hygienists for pain control, for local anesthetic administration: lidocaine, prilocaine, mepivacaine, bupivacaine, and the relative newcomer, which is articaine, which we're going to spend our time talking about today. Articaine was first introduced in Europe, and it had been available in Europe for over 20 years, but was finally approved for U.S. use in 2008. And this is when I started using this product about 10 years ago, when it was recently presented to our market. And I found just right away the benefits of it. We are being sponsored today by Purell Pharma, and they produce Orablock, and this is the articaine that I'm currently using, and it's available by your local drug rep that comes to see you, and order Orablock. So let's talk about the benefits of Orablock and articaine. It is a unique amide. Articaine is a unique amide. It has some unique properties from the other amides. It has a thiophene ring, or a sulfur-containing ring, and an ester side chain. So those are the 2 changes that were made to this specific chemical, with the thiophene ring and the ester side chain. So let's talk about these 2 benefits, these 2 changes in the chemical makeup, the chemistry that articaine has. The thiophene ring gives articaine a higher lipid solubility. And why is that important? Because it can diffuse through tissues better. It can diffuse and enhance the ability to cross the lipid membranes. And how does this apply to dentistry? My gosh, there are so many reasons why. I practice aesthetic dentistry, and typically when we are doing aesthetics, we need palatal anesthesia as well. And so when I do gain anesthesia, the nice part about articaine is that it does go through the tissues, hard and soft tissues. It crosses nicely through the bone, and oftentimes gives me enough anesthetic to be able to tap a cord, even around the palate, and not necessarily need to give palatal injections. So that's been a benefit for me. And as far as the ester side chain, the ester side chain contributes to the rapid breakdown of articaine once it's injected. And this decreases its toxicity potential. So as we move forward, this, to tell you a little bit of how this side chain allows metabolism to occur, mild local anesthetic agents are generally metabolized by microsomal enzymes in the liver. But articaine with its ester side chain is hydrolyzed primarily by plasma esterases in addition to the liver. So this plasma hydrolysis is a lot quicker, and it results in a much shorter half-life. And the clinical advantage of the short half-life is that there is less articaine accumulated and circulating in the blood. So you do the math. The shorter half-life of articaine can reduce the systemic toxicity that has occurred with other anesthetic agents. And when we're talking about the hygiene department, especially in full mouth disinfection, we need an anesthetic like this, because if we're going to provide full mouth disinfection in one appointment, sometimes the administration of anesthetics could be toxic to gain anesthesia in all four quadrants. I like this articaine also for my procedures with aesthetics because of its short half-life and ability for me to really work on a full upper arch and not worry about toxicity again. So when we're talking about maximum dosages, the maximum recommended dose of articaine for a healthy adult patient is 7 cartridges, but you got to remember an average of 7. So in a larger person, you might use 10. And the benefit is that we're using a 4% solution, unlike lidocaine, which the comparable cartridge administration maximum is about 8. Other unique articaine properties: unlike ester agents, articaine is not metabolized by PABA, and this is the responsible agent for most allergic reactions. So therefore, articaine poses little allergenicity threat. Definitely a benefit. So what does CRA say about articaine? Well, CRA, Clinical Research Associates, concluded that articaine has a fast onset, it's very profound, its infiltration properties allow restorative procedures without the need for a block, and this is what I was talking about being lipid soluble. So in instances where a hygienist is looking to maybe just scale 1 or 2 teeth at an appointment, at a typical prophylaxis appointment, she can do that with, with ease, especially with this system I'm going to talk about at the end, which is a needleless system. So all kinds of good, fun stuff to bring back to hygienists today. There's some other interesting facts. 84% reported that articaine produced anesthesia more profound than any other routinely used anesthetic, and that typically was lidocaine they were talking about. And since prilocaine and articaine are used in higher concentrations, the 4% solution, once again we said that the possibility exists that local anesthetics of higher concentrations are more neurotoxic. However, articaine does not have that problem because of how it's metabolized. And when I would look through all the risks associated with articaine and anesthesia, local anesthetic, CRA noted only 2 cases of paresthesia in 13,000 patients. But when we looked a little bit further at what those cases were, it looked like they were due to trauma. One patient had placement of an implant, and the implant caused paresthesia because of placement, and the other was due to nerve damage because of a surgical procedure. So even in those 2 cases, hardly was it because of the anesthetic. And I always believe safety first. So use informed consent anytime local anesthesia is administered in the hygiene room as well as in my treatment room. So the patient is aware of risks to adverse reactions, no matter how small. Safety first. So once again, as of 2006, there were 40 licensing jurisdictions in the United States which allowed dental hygienists to practice local anesthetic administration. We in Michigan do have the ability to allow our hygienists to administer anesthetic, and boy, is it a nice, of course they're not administering anesthetic when I'm not in the office, but it is a nice treat for me to be able to hand that off to the hygienist and get her job done efficiently instead of always, having to buzz the button and wait for me to get in for a simple procedure that could have just some really nice benefits for our patients, orally as well as systemically. I found this to be interesting in that Malamed does a lot of research, of course, with anesthetics, and he's probably the leading authoritarian on anesthetics, local anesthesia. And local anesthetics, as he reports, is the drug most widely used in oral health care. And he estimates that over 300 million local anesthetic injections are administered annually in the U.S., with nearly 6 million each week. I found that to be amazing in the United States alone. And there are few reports of adverse events, and certainly if there would be adverse events by dentists or dental hygienists, we would have known about it by now. So it's nice to know that we can block pain for our patients and really make significant health steps for them. As we move forward now, I'd like to talk a little bit about periodontal disease and how we tackle it in our office, and I would like to talk a little bit about a risk assessment model that we've learned at the Coy Center. In this risk assessment model, we break the practice down into the different categories that we treat: aesthetics, bite-related issues, gum-related issues and gum disease, decay and tooth-related issues, and of course emergencies. In addition, we've added breathing-related disorders to our category or our menu, and an overall fitness category, which includes knowing the patient's numbers as far as blood pressure, blood sugar, and overall fitness assessment as it relates to health and heart disease. So looking at this risk assessment model, this kind of becomes a patient's report card, and at that initial stage, and then as they proceed through treatment over the years in our practice, we're always trying to make recommendations to decrease their risk to a problem in the future. So as a patient comes in, let's look at a couple patients as it relates to gum disease. So, and as Gandhi said, it is health that is real wealth and not pieces of gold or silver. And I really do practice this model in my practice because truly just a pretty smile is a pretty smile, but a healthy, pretty smile makes just a positive impact on systemic health. So where do we start with periodontal disease? Certainly we need to evaluate risks for our patients, and therefore we can give them assessment as far as whether they're low, moderate, or high risk to periodontal disease now or in the future. And these 3 points are evaluated. We evaluate bone, we evaluate heredity, and certainly we evaluate home care. Those are the 3 primary points we evaluate. So let's look at John. You could at hello, you can see that he probably has a periodontal problem, especially around his central incisor. And let's take a look at his medical and dental history. When we look at just his pocketing and periodontal charting, you could see that he has 5 to 9 millimeters generalized pocketing. And when I looked at the radiographs, he had generalized recession and 30 to 50% bone loss generalized. He was certainly at least an AAP3. He was a 48-year-old CPA. It had been 3 years since his last simple cleaning and x-rays. He manually brushed, he did not floss, and he had moderate to heavy super and subgingival calculus deposits. You could see his blood pressure is elevated. He had leukoplakia in the lower left. He smoked a quarter pack of cigarettes a day. He took Lipitor and Plavix since his heart attack 2 years ago. And what we know now about the significance of periodontal disease and heart disease, it behooves us as healthcare providers to educate our patients and help bring them to a state of better systemic and cardiac health. He was taking aspirin daily, and he was a type 1 diabetic controlled by insulin. What do we also know about periodontal disease and diabetes? Definitely biodirectional. He was overweight, and here's the hereditary component. His parents wore dentures. So as we look at his gums, he's definitely high-risk perio. And in order to treat him, we're going to need to employ our hygienist, aren't we? So he's high risk for emergencies in the future, especially in the perio category. Let's look at another patient, Michael. Look at all this erosion at the gum line. No pocketing, just only in the upper left, 4 to 5 millimeters, which are localized. And he had 10% bone loss, and it was localized to the upper left. He was a 38-year-old father of 2. It had been 7 months since his last cleaning and bite wings. It had been 18 months since his last full mouth series. He does use a power brush and floss, and his blood pressure is within normal limits. He takes Nexium for acid reflux. We did note that we needed to go back and talk to him a little bit more about this Nexium to understand how long he had been taking it and what the impact his GERD or his gastric reflux and acidity was having on his erosion of his teeth. He had quit smoking 7 years ago and had a balanced diet. Although he did have elevated stress, he exercised regularly. And one negative point was that he drank power drinks daily, which was contributing to his demineralization cervically of his teeth. Patient was well aware and educated about gum disease, but with all this bone loss, minimal bone loss, but with all this tissue loss, he certainly needed to be treated differently by the hygienist. He had high-risk perio, and as we moved forward, we did a tunnel technique alloderm graft, and this was just 1 week post-op, and he was healing well. But he was still going to need to be in our recare system with the perio, and the hygienist at times had found herself needing some local anesthetic just to manage some few sensitive areas. So we know a lot about the oral systemic connection, that periodontal disease contributes to heart disease, stroke, diabetes, respiratory disease, and preterm low birth weight babies. And as we move forward, we are educating our patients to get healthier. One of the systems that I use in my practice is bacterial testing, and I use the system that's made by my periopath. It's one of the testings that we use, and we test for 11 pathogens that cause periodontal disease. It takes about 4 to 5 days to turn around this test, and the way the report reveals is that it tells us what bugs are in the mouth specifically, so that we could make specific recommendations for antibiotics to be used during scaling and root planing and complete disinfection. And this is what the report looks like. You could see that there's this black line. This is the threshold line. And these are high-risk pathogens, moderate-risk pathogens, and low-risk pathogens. These are the pathogens that are causing the gum disease. Many in this patient's mouth are high risk. They're, low risk. They're above the threshold line. You can see these 2 pathogens are above the threshold line, and look at these 2 high-risk pathogens that are above the threshold line. Through this report, we are given recommendations for specific antibiotics to administer during the scaling and root planing process. And of course, along with probiotics, we recommend, along with antibiotics, we recommend probiotics to be taken to protect the gut. Another test that we can run is a genetic test for periodontal disease. We would typically run this test. Either this determines the patient's genetic susceptibility to periodontal disease, and it takes about 8 to 10 days. Once again, this is a spit in a cup test, and the saliva is sent to the lab. And why would we choose to use a test like this? Well, if we find a patient, say for example a young patient that may only have one area of pocketing, we might decide to use this test to see if they are highly susceptible to gum disease through having the gene for gum disease. And if they are, we might choose to watch them much closer instead of just waiting for periodontal disease to spread to other areas. So we've used the genetic test before. We don't use it a lot. We use the other saliva testing for bacteria a lot more frequently, but this test is available. And this is what the test looks like. It tests for that specific point in time, and it tests to see if you have the genome and the genotype, and you get a positive or negative result. And once again, if you come back positive, it tells you the significance of the test, the risk of the test, in that the prevalence of a positive genotype ranges, and it tells you 30 to 40% in the Caucasian population, and it continues on to tell you the significance of it and why you might want to be more proactive with your periodontal health. So what is it that we're treating? We're treating periodontal disease. So what? And here's where the rubber meets the road. You as hygienists out there and you as doctors out there kind of guiding your hygiene department, are we going to continue just to clean teeth? Treating over and over again with the same results? That's kind of insanity, isn't it? So once we find periodontal disease, with all this research that science has given us and with all these new opportunities for us, now what? Let's treat the disease. Let's just not continue to clean and leave those bacteria in the bottom of the moats floating around, because a simple cleaning, you know, doesn't get to the bottom of the moat. So we need to begin identifying predisposition to disease to prevent it. If someone is more predisposed, we must be more proactive about the disease. So what's the problem? The problem isn't any longer just that people don't clean their teeth, because haven't you seen that patient that comes in? They haven't been in 8 years, 10 years. Maybe they've never been to the dentist. And they come in and their teeth actually look pretty good. So if that were the case, what we've learned about science is that periodontal disease is much about a patient's genetic factors than a lot else, and their medical history, their social history, their habits and their stresses, as you saw in the 2 patients that I presented. So it isn't just about home care anymore. Science has taught us that. And it behooves us to start teaching our patients that too. And genetics plays such a bigger part than we were ever aware. So in our practices, yes, we're trying to maximize efficiency, increase profitability, simplify our lives, have superior patient experiences, be consistent with our care. We need to be simple and cost-effective, and certainly increase case acceptance. So if we can manage pain appropriately, this can help us with case acceptance and moving forward. Once again, here's another bacterial test. As you can see, this is Roger. Roger had periodontal disease. He was actually coming to me referred by a cardiologist. He was ready to go in and have some cardiac surgery, and the doctor asked if he had seen his dentist recently. And what this bacterial test, as you saw from before, shows us, this is the pre-test and this is the post-test. This is the test before gum treatment, and this is the test after gum treatment. So before scaling and root planing with antibiotic use, and after. The test was done a couple weeks after, prior to Roger going in to have heart surgery. So looking at the test before, you could see his high risk. He had 1 pathogen almost to the line, moderate risk, 2 pathogens above the line, and low risk pathogens were above the line. And after our gum treatment, you could see the efficacy of our scaling and root planing procedure and antibiotic protocols. We had targeted the right bugs, and look at these pathogens and how much we had under control. So you could see scaling and root planing is very effective, and we managed it with great pain management through anesthetic and using articaine throughout the process. So as you move forward in your practice, you might choose these steps to minimizing your patient's risk to gum disease. Quit smoking, see their dentist every 3 months. We customize this plan. So if they're diabetic, we do monitor their A1C. We use manual methods that they're going to employ, because sometimes we can make recommendations of a water pick or flossing to minimize bacterial load, but if a patient is not going to pick up a water pick, to make recommendations for that are futile. So we need to modify sometimes our recommendations to fit their needs. We also use toothpaste that are pH neutral to minimize the bacteria, and I like carie-free products because they have xylitol in their products, which is a certain chemical that tricks the bugs. It's a sugar substitute and it kills bugs. It also has a pH balancer in it. It's low abrasivity, and I like it because it also has 5,000 parts per million of fluoride if I so choose to use it, and it can help with desensitizing after our scaling and root planing. As far as mouthwashes are concerned, I'm really fastidious about which mouthwashes my patients use, and for periodontal scaling and root planing protocols, I am very conscientious of the acidity of the mouth rinses, and I would advise you to do the same. Carie-free also makes a mouth rinse that's a treatment rinse, and the pH is about 10.3. You'll never find any other treatment rinse or rinse on the market that comes anywhere near close to that. The next mouth rinse on the market falls in at about a pH of 8, and that is also a carie-free maintenance protocol, a carie-free maintenance rinse that can be used every day. And another good mouth rinse on the market is ACT mouth rinse for cavities. That's something that it's an anti-cavity rinse that can be purchased at the grocery store, and I love it. I like to explain to patients the acid-base scale, and that it goes from 0 to 14, certainly 7 being neutral. 0 is more acidic, all the way up to 14, which is more basic. And the bugs in our mouth, especially those in gum disease, very much like a very acidic environment. So if we can dump something very basic on them, we can almost kill those bugs on contact. That treatment rinse by carie-free, the 10.3 pH treatment rinse, kills the bugs in 3 seconds. We do have our patients rinse with it for a minute, but you know when you tell patients to rinse for a minute, what do you get? You're lucky if you get 20 seconds. So I like to get my patients using the treatment rinse daily while they're going through scaling and root planing. They're using it at least twice a day, and some of my patients are on this rinse for the rest of their lives. However, we believe in a risk assessment model and a really a customized platform and a customized care schedule for patients that are going to fit their lifestyles and treat them individually. Once again, we usually recommend a water pick, and we do use modalities and rinses that we can add to the water to make the water more basic in the water pick. So there are a lot of little customizable steps we can use to treat our periodontal patients. But you know, if you don't get the bugs out of the pocket and treat scaling and root planing efficiently and effectively, there's no way to get rid of the gum disease. So especially once there's been bone loss and there's been tissue pocketing, it's very difficult for patients to maintain themselves. So employing some of these techniques, and especially gum disinfection in the office, is an absolute necessity. A lot of the research out there says that if you are not seeing 35% of your patients in your practice go through the hygiene department with periodontal treatment, as in periodontal maintenance or scaling and root planing procedures a day, you're not treating periodontal disease properly in your practice. So that's something we really take seriously in our practice, identifying what periodontal disease is, and as we move forward here, maybe I can help you a little bit more. Of course, using a tongue scraper, and we employ laser-assisted periodontal therapy in our practice. But once again, without proper pain management and anesthesia, these practice modalities are not feasible, because I can't keep getting up out of my chair to help the hygienist get her job done every time she needs anesthetic. So take a look at this laser-assisted periodontal therapy. It's really slick, and we use it every day in our practice. The hygienist is able to use it in my state. After she gains anesthesia, she's able to use the laser to slough dead tissue, and after sloughing the necrotic tissue, she's able to use ultrasonic instrumentation and hand instrumentation. So she uses the laser to slough the dead tissue on the inside of the cup. I don't believe in using as much Arrestin as I used to, because I really believe that when we use Arrestin, we're relying on the body to slough that tissue, and I've found much more success with the hot laser, which needs anesthesia. And then she goes back with hand instrumentation and the ultrasonic instruments, and finally stimulates at the bottom of a cuff for new bone growth and new tissue attachment. And this has been a game changer in my practice, but once again, without proper pain management and anesthesia, this wouldn't be possible. I really feel that I've given my hygienist the ability to soar in our hygiene department and make wonderful progress for our patients, getting them healthier, because you can have a healthy mouth and be sick somewhere else in your body, but you can't have an unhealthy mouth and be healthy systemically. So this is something else that I share in my practice. The hygienist has this on her screen, and what does it mean to bleed? I believe that every practice, every hygiene department should have a barometer for what you feel is normal. And we have a no tolerance policy in our office for bleeding, and as we measure bleeding, we're really talking about line bleeding. So you can see as you move through these grades, we all want to be on the same page with the same terminology. So this is a grade 1, and you can see it's point bleeding. See that little point of bleeding here? Grade 2 is line bleeding. You can see how it starts to bleed down the line of the tooth, the blood does. This is triangular bleeding, and this is droplet blood. And so in my practice, we've agreed as a team that line bleeding, 4 or more sites of line bleeding, 4 sites is our barometer. If a patient has more than 4 sites of bleeding, we are recommending some periodontal therapy. We might recommend them coming back in 6 weeks just to see if they can beef up their home care. However, at that point, if things are the same, we're going to make some recommendations for scaling and root planing and gum disinfection. So this chart is up and available to patients and to the hygienist, so we're all on the same page with terminology and policies in our office. So when the patient, when the hygienist does her probing, she's using headphones typically and charting at least once a year on our patients. She's assessing these sites of bleeding, 3 sites on the cheek side of the teeth and 3 sites on the tongue. And if there are more than 4 sites of bleeding total throughout the whole mouth, we're making some type of recommendation, something that is customized and will fit with our patients' lifestyles. We are also very clear in our practice about what gum disease is. So as we go through, we can have healthy gum tissue. And what does health mean? 1 to 3 millimeter cuffs, no clinical attachment loss, no bleeding upon probing, no bone loss. As we move into gingivitis, early perio, moderate perio, severe perio, and aggressive refractory perio. We have calculations for each of these categories that our team is very familiar with. Everyone from the front desk to the back desk are familiar with these, because these categories generate our, obviously to the end, our reevaluation and continuing care, but also all of our billing. So from start to finish, everyone is aware of the different categories of gum disease, just like they might be aware of the different categories of bite disease. And as I said, I did have something to offer you, a little bonus at the end here. And this bonus is something that's been fun in my practice, and it's a numbie. It's a needleless anesthetic, and it's been great with my Orablock, my Articaine that I use routinely, because now with this numbie, the hygienist can even do just localized areas of scaling and root planing at the same time that she's performing a simple prophylaxis. So it's also great for pedo patients. And I'm going to get you a little closer look. There's not a needle on the end, and it's so cool. The numbie is a patent pending device, and it's used in it can be used in a regular syringe, but it can also be used in a periodontal ligament syringe. I'll show you what that looks like. And patients can actually touch the blunt tip, and they'll see there's not a needle at the end of the tip. And it allows really quick, localized anesthetic without lip or tongue anesthesia. So once again, it attaches to a standard syringe and a Ligajet. There's no expensive hardware required. It's OSHA friendly and eliminates needle sticks, and it's just been fun. So this is what it looks like. You can see this end screws into the hub of your Ligajet or your typical syringe, and this is what the patient could see or touch. It is basically a little Teflon sheath, a hard Teflon, that houses a little needle that you can't even see in the middle. And this tip gets inserted in the periodontal pocket, and just like a Ligajet, the Ligajet is pushed and the anesthetic solution diffuses into the cuff and gets the tissue numb. They're sold in boxes of 40, and the retail price is about 50 bucks, and they're individually wrapped and sterilized. This is the Ligajet. So it costs about 275 bucks, and most people have at least one in their practice. So pull it out and order some numbies, and let your hygienist play, or let you play. I've used it. Once again, there's no needle, there's less pain, and I've used it actually quite a few times, and I'm using it more and more frequently in cementing my crown so as not to have to give a block at the crown seat. I can just infiltrate in the periodontal ligament, and if I need, insert some retraction to get my tissue pulled out of the way and get a nice dry field and cement my crown. Of course, this simplifies anesthetics. It reduces anxiety and fear of the patient. It's for single tooth anesthesia, like I said, so it's when you're targeting 1 or 2 teeth for periodontal purposes. It's great for the hygienist. And both sides of the mouth can be worked on during the same visit, just like we do when we're completing scaling and root planing procedures. Patient benefits, once again, are there's quicker time for numbness as compared to a traditional nerve block. The lips, the cheek, and the tongue don't get numb. Of course, there are no needle punctures for unwanted bacterial soreness or bacterial invasion. We can use traditional anesthetic syringes with it, and their duration is about 30 minutes. And here's a little video which demonstrates how it can be used in the pedo practice, and this is basically what I do and our hygienist does in our practice. You can see that little wand is inserted into the periodontal pocket, and the anesthetic is deposited. You can see the doctor pushing on the Ligajet handle to dispense the anesthetic solution into the cuff, and it's all a pressurized system, and once the cheek side is anesthetized, you can go to the palate, and this would be the procedure certainly for periodontal scaling and root planing of a single or two teeth. You can see how simple it is. Almost done. And this is a pedo patient. You can see she really didn't feel much, if anything at all. So I think this is just a game changer for the perio practice. And once again, you can learn more about that on your own at novaject.com. And I really want to leave you today with remembering the benefits of using Articaine, needleless or not. So once again, Articaine, I love using it in my practice because it is really metabolized very quickly. It's nice for full mouth scaling and root planing. It's nice for my longer procedures in which I'm working on a full upper and maybe even a lower arch at the same time. We can get effective nerve blocks with it. I no longer have to get someone numb and leave for 10 minutes. I remember early on in my career, that was what I did. I actually set the timer for 10 minutes and left the room. I gain anesthesia, and by the time I've just, 60 seconds in, I'm ready to begin my procedure. So because of its strength at 4%, I need to use less anesthetic. And truly, the research shows that there are less percentages of nerve block missing, and because I believe of its infiltration potential and its lipid solubility. And once again, it's really efficient in bone diffusion through the palate. So whether you have Articaine in your practices and you're using it, and the big step for you is really to get your hygienist involved with the system, or just start using it yourself. I believe Articaine is the way to go, and that truly is the system that I use the most in my practice. It's a system that you can use on everyone 4 years and older, and so why would I use anything else? The only other system I have in my practice is an anesthetic that has no epinephrine, and it has carbocaine. So those are the two anesthetics that I practice with, and practice successfully with just those two. So I encourage you to consider OraBlock by Puro Pharma because of its lipid solubility, its high plasma protein binding rate, its fast metabolization and elimination half-life, and low blood levels. So I want to thank you for listening today. If you have any questions or concerns, you can always reach me. I can be reached at 313-882-2000, or please feel free to contact your local rep and get some more information about OraBlock and OraBlock Articaine by Puro Pharma. So thanks again for having me. Any questions? I see one question here. Yes, I am using Articane for blocks, and all the research shows there's no problem. You can pull the research off of the OraBlock website. There was a question about lasers. I'm reading my questions here. I've had no side effects to Articane. There's a question about lasers. I use a diode laser in my practice. It's a hot laser. I also use a diode laser on a cold setting for gum decontamination prior to scaling and root planing. And I also have a water laser in my practice. So I've employed many anesthetics in my practice. I've never had a problem with paresthesia. As far as the Numbi and Aura-Kicks, they're not the same thing at all. I found, because I'm using Articane with the Numbi, I'm using my own anesthetic with the Numbi. The Numbi is simply a administration tool. It's like using just a syringe. It's not the anesthetic at all. I don't see any other questions. I don't know about what companies sell OraBlock. I do know that it's a Puro Pharma product, and typically it's available through any supplier. There was a question about rinsing with hydrogen peroxide. You know, the hydrogen peroxide really isn't strong enough to make a maximum difference. I like to keep my recommendations all scientifically based, and for that reason, I prefer to use something that is tried and true, and I only make recommendations, once again, that are scientifically based, and certainly the Carry-Free products are. And there was a question about saliva DNA testing. As far as the testing, I don't bill that through insurance. It's a fee-for-service product, and I think we charge about $150. And there was a question about, specifically, is Carry-Free high pH rinse? What is it? It's CTX. Look under Carry-Free on the computer, and you'll see all the products. The highest pH product is the CTX4, and it has a pH of 10.3. And Carry-Free is a great company for resources as far as periodontal products. Once again, I've never had a side effect with Articane in my practice, and I use it routinely, and I love it. And my hygienist uses it as well. Okay, I thank everybody for listening to our presentation today, and Puro Pharma thanks you. And if you have any questions about safety of the product, certainly ask your rep and go online to OraBlock and have any of your other questions answered there. So thanks again for having me, and I hope to help you in the future. Bye-bye.